So there's lots of things we don't know about ocular melanoma, and so we have to try and fill in some of these gaps, and that's sort of why we're doing research to work out all these things, all these gaps to fill in. I know we've talked about some of the surveillance issues. I don't need to tell you about ocular melanoma. What I do need to tell you, though, is what we need to do is we are moving more and more towards finding out who's at risk once they have their ocular melanoma either removed or biopsied if they have a plaque book in. Why does that help? One, because we can convey information. You don't have to have the information. Some people, we've even talked about earlier in this meeting, a person who wanted the test done but didn't even want to know the result. They said, don't tell me the result, but I want the test done. Other patients want to know the result, other patients don't want to have the test done at all. It tells you what's the chance of the cancer coming back. And here's some examples from one of the tests. It tells you what's the chance of the cancer coming back at 3 years and 5 years, depending on what genes are found when you do the analysis. And you can, that's a new funky way to do it. The people in Liverpool, Dr. D'Amato, developed this thing called LUMPO, and you can put from your pathology port that Dr. Svetlana put in, you can put all the stuff in here, and then it can give you a chance of what your cancer is, the chance of coming back. And so that's also available even online to put your numbers in, and you can see what's what. There is a test in the United States, which is about 7,000 Australian dollars, which you don't need to have, but people will talk about it, you'll hear about it on Facebook and whatever, and that will give you a certain recurrence risk, and this is a very good test. The test that Dr. Cherepanov does is very much similar to this test. It does it in a slightly different way. This looks at RNA, her test looks at DNA, but the results are very similar in terms of telling you how likely is the cancer is to come back, and so you get numbers. This is the fancy $7,000 test, and obviously there's been a bit of controversy because some people say, what's the point of having the test if I don't have a treatment if the test is positive? So as you can see, the way they're advertising this test is they're saying it's, I was grateful for my doctor who was experienced enough to advocate for the test. She's not exactly saying this test saved my life, because the test didn't save her life. She was very happy the doctor thought about it. So we have to be sometimes a little bit skeptical about some of the advertising we see, and it's very much a patient decision. Do you want to have the test when your eye gets removed? So that's one aspect that I deal with. The other aspect that I deal with when I talk to my patients is, how often do we do scans? And so we've had some discussions about what's the best scan, how often should I have the scan, and generally speaking, the bottom line is MRIs are probably the best. They see the smallest things, that's all this says. CT scans, CT PET scans in particular are also pretty good. MRI scans, sometimes your local hospital will pay for them, sometimes you might have to pay for them yourself. PET scans for melanoma are covered by the government, so there's some financial considerations. And people have compared them, what's the chance in terms of how accurate they are, but that's summarising that table. The MRIs are probably the best because you can pick something up at an MRI which is a couple of millimetres in size, but you can't see that on a CT scan. Now, how often should I have the scans is often a question I get asked. And so fortunately, just late last year, the Americans spent a lot of money into this thing called an NCCN guideline. And so they said, look, depending on how aggressive the cancer is, and this is, we can look at some of these things even on a simple pathology report that Dr. Svetlana can see under the microscope, we can then make some recommendations. So if we do some of the chromosome analysis she does, then they recommended that they have the scans every 3 to 6 months for 5 years, then every 6 to 12 months for 10 years. And what we know from some of Dr. D'Amato's work is, this is not cutaneous melanoma. So if you have a cutaneous melanoma removed, after a couple of years, the chance of it coming back is probably close to single digits, if not zero. But that's not the case in ocular melanoma. And so we've had some discussions that someone's oncologist told them that after 2 or 3 years, the ocular melanoma is not to come back, and that's unfortunately not true. So that's one thing that you may have to educate your doctors about, and certainly we're getting the message out there. But this now is available. You can print this out. In fact, I think I put it up on the Facebook group, the whole PDF of 55 pages, so you can download that and find this page, and you can shove it under your ophthalmologist or your oncologist's face and say, this is what the Americans do, this is the guideline. So, so it's very much patient-based and risk-based. And there are some statistics around how often it is you need to do these things and how effective they are, but it's very much you know, we're looking at up to 10 years of scanning, certainly for a high-risk melanoma. Can you give any treatment to prevent the melanoma coming back? The answer is we don't know, but people have tried and they keep trying. But generally speaking, as an oncologist, what I know is if there's a treatment that works well to kill the cancer when the cancer is spread, that treatment will work well to kill the cancer when the cancer has only microscopically spread and I can't see it. So at the moment, I don't have any treatments at the moment that kill the cancer well enough when the cancer is spread that I can say for sure you should have this drug, even though your cancer may not be there, but just to mop up any spare cells that might be left around. We're working hard on that, but at the moment I don't have any, but we're certainly trying. Now, to treat the melanoma itself, once it's spread, just to give you an idea of what's around there, there's a long list of things you can put inside the liver to kill tumours. So some of those things are available in certain states, and some of those things cost money, some of those things don't cost money. Putting chemo directly in the liver actually doesn't cause that many side effects, so you're not actually putting it into people's brains that make them vomit. We can do that here at St Vincent's. You can do that in a few places around the country. You can put radioactive spheres into the liver as well, and often private insurance will cover that, for example, or you can just block off blood vessels that supply tumours. So all these things can be done, and they work quite well. We did a recent analysis to show that if someone was well enough to have some of these things done, that's actually a very good option. What we like doing as oncologists is we like turning the brakes on the tumour. So we know sometimes in ocular melanoma what makes a tumour grow is that this thing, there's a mutation here, and this whole cascade of events comes out, and then at the end of the thing, the cell grows. So what we like doing as oncologists is we like putting the key in the lock and turning off the motor. So at the moment we don't have a key, though. We just know the motor's running, and I can't put the handbrake up, let alone turn the engine off. But we are getting ideas of things that actually slow down the tumour, and some of these things are still being investigated. So there was a drug here I was involved in. It worked in about 14% of people. There was a drug here that one of the researchers presented yesterday, just in mice, worked in a few mice. There's a recent paper that came out a few weeks ago that maybe all that matters in this waterfall of terrible things happening is all that matters is this thing up here, and you need to block something here. So, but no one's actually tested that in a human being yet, although these drugs exist, but no one thought to give them to patients with ocular melanoma. So we're working on shoving the key in the engine and turning it off, but we don't have that yet. And this is some of the examples of trials that didn't work, where we started to give some of those things together, and you can see that between the blue line, which is with the drug, and the yellow line without the drug, nothing happened. What is exciting is immune treatment. So we have different drugs. One drug here is called ipilimumab. Jess talked about that. That turns on what I call the master switch in the immune system. We have another drug called nivolumab or pembrolizumab that takes away the force field that keeps the immune system out from the cancer. So the cancer sees the immune cells coming on, puts up a force field, and the immune system cells can't get in. So we have drugs that block that. So then turn on the master switch, turn off the force field around the tumour. Does it work? So rarely. So here's an example of someone, 76-year-old female, and you can see that she's got some cancer that's spread, and then after 24 months of this drug, it's gone. So it does happen. I've seen it happen. This drug is available on the PBS. The chance of it happening, unfortunately, is not very high. So here's an example where, here's a study I was involved in, which is one of the master switch drugs. Number of patients responded was 0, and you can see that people keep trying. With different drugs alone and in combination, but we're not seeing anything dramatic in this column. This is response rate. We're not seeing anything dramatic in that column that I can say, this is amazing, turning on the immune system works very well. They've tried now putting those two drugs together, and this is probably as good as we have in terms of the standard immune treatment for ocular melanoma, and you can see here patients lived for about 14.3 months compared to 8, and these two combination drugs, however, are not available on the PBS currently for reasons are not clear to me. When the government approved these drugs for skin melanoma, they specifically put the wording they're not available for ocular melanoma. And that may be because in skin melanoma, their drugs work very well, so the line is up here, but we don't have access to those drugs other than, as Jess suggested, purchasing them anymore for patients with ocular melanoma. You can have one drug, then the other drug, but you can't have them together. So that's unfortunate, but what it does mean is that we have to look at other things. So the Americans have this treatment called TIL therapy, where they take out the tumour, they take out the immune cells, they grow them up in the lab, and then they put them back in the patient. So the patient starts off with, let's say, 500 immune cells which are trying to attack the cancer. They grow up in the lab and there's all of a sudden 5.5 billion cells, and they give them back to the patient. And look, sometimes that works. Here's some tumours shrinking. But the trouble is this is done in Washington, D.C. They actually will accept Australian patients. We have to go there and live there for a number of months to get the treatment. And it's free, and sometimes it works. So, but what we do have now in Australia, in Sydney, Melbourne and Adelaide, is a clinical trial with an immune treatment here that is actually quite promising. So why is it promising? This is the drug, and it looks very funny, but what it does is this bit down the bottom will attach to an immune cell, any immune cell that's flying past. And this is like a, well, it looks like something irritating, and it irritates the immune cell to attack anything that's up there. So these immune cells are flying past, they hook onto this, and then they attack. This thing binds onto the melanoma. And what it does is this bit here binds the melanoma itself, and this bit here is part of someone's immune system. So all the patients that go on this drug have to have their immune system checked to check they're the most common Caucasian immune system, and we check their immune system, and you can see here that this is that thing which is called GP100, and in eye melanoma it's very, very highly expressed. So it seems to, and we give increasing doses of the stuff, and they've tested now, I'll talk to you about these 19 patients, and of those 19 patients, they're actually surviving, about 73% of them surviving a year, which is actually very good for ocular melanoma. So now, and some of them had their tumours shrink. I'll show you that picture here. So some of them are shrinking. So this is quite a exciting moment for oncologists to see that we have a drug which activates the immune system to attack the melanoma, even though the melanoma is a nasty bastard. And we've got something now that might work. And so what we have to do, unfortunately, is we have to do a trial. So that means, that trial means the company comes to the FDA, comes to the government in Canberra and says, we want to sell this drug. It's going to cost a lot of money. And they said, well, you can do that. You have to show it's better than what we have before. So when the patients come for this trial, I talk to them about this. I say, look, you know, it's quite exciting that compared to 2 years, this is where we were before, but with this drug, there's some early data. It's quite promising. I can't tell you for sure. This is only 19 patients. This is not hundreds of patients, that it might work. So there's for every 3 patients to go on this trial, 2 get this immune drug, and 1 will get another type of immunotherapy, which you can discuss with the doctor. And so that's how the trial works. And then when the trial's finished, they'll see of those patients who got the immune drug, how much better did they do than the people who got the normal drug, and we'll see. So I don't know what the answer to that is. All I know it's a promising treatment, and as such, we're offering it to patients. And there's some data that suggests that if you, for example, if you have a nasty rash, you're doing better, maybe because there's more drug getting into the body and the drug is activating the immune system to a greater extent. We will see. And then here's some examples of patients who have had this drug in the dark blue, and then they've had other things. And so maybe if you turn on the immune system with other things later, and that some of my patients have had other drugs after this drug to turn on the immune system, maybe you'll get more action. So we're working on that. So those are the things that take up my time with my patients with ocular melanoma. There are lots of other things we're working on. We've got other trials coming with other drugs which bind to the ocular melanoma and attack it, either by delivering chemotherapy precisely just to the tumour or by getting the immune system to attack the tumour. And those treatments are still in investigational phase. Those drug trials are called phase 1 drug trials, which means we're still learning the side effects and we're still learning the doses. And I would like to give you a laundry list of those trials, but those trials sort of change month to month. So what I say today may not apply next week in terms of ocular melanoma, but that's sort of the conversation, and I'm happy to have that with anyone at any time.